Hello, Dr. Karanis. Can we do a mic check, please?
Sorry, good afternoon. Can you hear me?
Yes, thank you very much.
Perfect, thank you.
This is a courtesy announcement that our meeting is now broadcast live on YouTube and our web portal.
Hi, Jackie. Can we do a mic check, please?
Good afternoon.
Good afternoon. We can see you and we can hear you. Thanks very much.
Thank you.
Hello, Catherine. Can we do a mic check, please?
Yes, can you hear me okay?
Yes, I can. Thank you.
Thank you.
Dr. Miller, can we do a mic check, please?
Why, sure, here I am.
Thank you. Hi, Miguel. Can we do a mic check, please?
Hi, can you hear me?
Yes, I can hear you. Thanks. Hello, Supervisor Simidian. Can we do a mic check, please?
Thanks, Dave. This is County Supervisor Joe Simidian. Am I coming through loud and clear?
You are. Thank you very much. I'll be turning it over to Jess in just a couple of minutes. She'll be clerking the meeting for you.
Thanks so much.
Hello, Dr. Cody. Can we do a mic check, please?
Hi, can you hear me okay?
Yes, thank you.
Great, thank you.
Hello, Supervisor Lee. Can we do a mic check when you're ready, please?
Yes, thank you. Can you hear me okay?
Yes, we can hear you. Thank you.
Perfect.
Hello, this is Wanda McClinton-Brown. Just want to make sure you can hear me.
All right, good afternoon. Thank you very much. It is 2 o'clock and we are going to call this meeting of our Santa Clara County Health and Hospital Committee to order. And I am going to ask that if you are on the call and should be muting your mic, that you take this opportunity to do so. Let's ask the clerk to call the meeting to order with a roll call to establish the presence of a quorum.
Vice Chairperson Lee.
Present?
Thank you. Chairperson Semidian.
And present. So thank you very much. We have a quorum, and that takes us to item number 2, which is public comment. That portion of our agenda set aside for comment by members of the public on non-agendized items, items that are not on our agenda, but that are properly within the jurisdiction of our committee. Let me turn to the clerk and ask, do we have folks who have indicated a wish to speak under public comment?
Yes, we do.
And how many do we have, if I may ask?
One request.
All right, let's hear from that one public comment speaker and allow him or her up to 3 minutes. Thank you. Thank you.
Our first speaker is Scott Largent. I'm unmuting you. Please accept the unmute. You will have 3 minutes to speak. The timer will start when you begin speaking.
Thank you. Good afternoon, everyone. Scott Largent. I am really looking forward to getting back into the chambers to have normal meetings. I'm sure all of you kind of feel the same. I am zoomed out, but it'll be nice when the in-person thing starts again. I utilize that as kind of like my support group, therapy, and certain things that I thought I would have been able to have obtained from the county. But since I'm not a felon and since I'm not on probation or parole, those are resources I will never be able to tap. Now, I would like to talk about Judge Stephen Manley today. Now, Judge Manley had me arrested in his courtroom. Now, I'm not a Judge Manley patient, like many of you probably think I am. I was there to advocate for a woman, Simple Rose, Sumatra Rose. Very, very nice woman. You supervisors have seen her come in there for comment prior to COVID. And this woman's being railroaded out of the city of Campbell. She was shoved into a so-called voluntary diversion program. It was basically the Manley hustle. She was Manley. Several judges basically told Rose everything she wanted to hear. Same with myself as being there as an advocate. Same with Robert Aguirre. And they shuffled her into Manley's courtroom. I was very concerned that they were making all these promises to Rose. They were saying that they were going to house her, return her property, protect her rights. You know, here's our whole entire team that is there to help put your life back together, help you with your issues. It all sounded great, but it's all show, no go. 20 years ago, Judge Manley's courtroom worked properly. Today, it doesn't function at all. It's just a big dead horse, and I am very frustrated. So after Rose was put up on the chopping block in there, we kept trying to contact her attorneys. You know, she's rotated between, I believe, 16 different attorneys. And in court, Manley starts talking to her right away, out of the presence in a way of her attorney. And sitting back, and when you're watching this poor woman kind of fumble, she's trying to talk, you're there to advocate for her. I just cannot stand for that. And so I started to speak up. An old pirate judge does not like members of the public making comments in his courtroom. And I do get it, he is a judge, but I called him out on his dirty deeds. I said, this is unacceptable. You know, you're violating this woman's rights. And he just dragged me out of the courtroom. Of course, they're not prosecuting me, but I did spend the day in the pokey. You guys need to do the proper work to figure out how your system is failing our community before you implement Laura's Law. Laura's Law is the nuclear option for the fact that this stuff is garbage right now. You guys know it doesn't work. You look out on our streets, but do the homework, Joe. You guys talk a big game about wanting to do the nuclear option. Understand what currently does not work. Thank you.
That
All
concludes our
right.
requests.
Let me go back to our clerk. And do I understand correctly that that was the only speaker for public comment?
Correct.
Thank you very much. Then Supervisor Lee, that will take us to item number 3 on our agenda to approve the consent calendar and any changes to the committee agenda. If you are so inclined, I would be pleased to entertain a motion to approve the consent calendar and the agenda as published. Thank you. We have a motion by Supervisor Lee. We have a second from me. Let me turn to the clerk, see if we have any speakers on the consent calendar.
I see no requests.
Thank you. Then we'll ask you to call the roll, please.
Vice Chairperson Lee.
Aye.
Chairperson Semidian.
Aye. All right. Thank you very much. That takes us to item number 4. which is to consider recommendations relating to medical staff and allied health professionals at our various hospitals and within the system. Do we have someone here to present on that item? I think we do.
Yes, we do. Good afternoon, Supervisor Simidian and Supervisor Lee. My name is Yvonne Karanis, and I'm the Enterprise President of the Medical Staff. I'm here to present the Enterprise Credentials Report, as well as the revised Enterprise Anesthesia Privileges, which reflect our ability to offer pain management services at St. Louis Regional Hospital now, and answer any questions that you might have. Thank you.
Thank you. Supervisor Lee, I have no questions or comments today. The agenda and the enclosure identify possible actions A and B under item number 4. Are you prepared to move approval, or do you have comments or questions first?
Actually, I have no comments either, correct? And I'm ready to
all right.
move forward as well.
All right, then for the clerk and the record, we have a motion to approve. We have a second by, the motion to approve is from Supervisor Lee. The second is by me, Supervisor Simidian, for the record. Let me confirm with the clerk. Do we have any speakers on this item?
We do not.
Then let me ask that you call the roll, please.
Vice Chairperson Lee,
Aye.
Chairperson Simidian.
Aye. Thank you very much, Dr. Karanis, and appreciate you being with us today. And
Thank
that takes
you.
to item number 5, which is to receive report from the public health officer and her team relating to vaccines and COVID-19. And why don't we see who is going to start us off with that presentation today.
Thank you, Supervisor Simidian. This is Dr. Cody joining, and I will begin. I think Dr. Fensterscheib, if he can get off another call, will also join me, particularly for question and answer. So my report today is fairly brief. If I could have the first slide, I will give you a brief update on the epi trends, which are all extraordinarily positive, as well as an update on how we're doing with our COVID-19 vaccination program. Next slide. As you may know, if you are a watcher of the county's dashboard, you will see that our daily case counts are steadily marching down. It's a slow and steady decline, a bit lower every day. Right for the last several days, when we look at the new number of cases reported, it's sort of more in the 25 case range, which is notable because it's continuous. So that is excellent news. And in the next slide, well, actually, go back, I'm sorry. I want you to just notice that the 7-day rolling average number of new cases is now 50 as of yesterday. And the last time that we had a 7-day rolling average that low was the middle of June of 2020. However, so look at those two, put those two in your head if you look on this dashboard, and then jump to the next slide, which shows our testing. And you can see that now the amount of testing that we're doing, while it has decreased a bit, it's still over 3 times the amount of testing that we were doing in mid June 2020. In other words, we have fewer cases now than we did in June 2020. And the positivity rate is currently 0.5%. This is our dashboard yesterday, which says 0.6 because it has a longer lag, but it's actually around 0.5, which is the lowest it has ever been for the entirety of the pandemic. So we are looking pretty darn good. In the next slide, these are our deaths, and we have had, of course, almost 2,100 lives lost to COVID. However, the good news is that the number of deaths each week are now very, very, very few and continue to decrease. The next slide is around COVID vaccine. I'll just give the overview, and I've just been joined by Dr. Fensterscheib, who can walk us through the slides. But the bottom line is around who's eligible. Since we last presented, eligibility is now expanded to anyone 12 years of age and older, because the emergency use authorization for the Pfizer vaccine has been extended to include 12 to 15-year-olds, and anyone from anywhere can come and get vaccinated in our county. You no longer need to live, work, or study in the county to come to one of our vaccination sites and get a vaccine. I'm going to turn this over to Dr. Fensterscheib. One moment. Dr. Fensterscheib has now joined me. We'll talk a little bit about the strategies that we have to reach our under-vaccinated groups in the county.
Thank you, Dr. Cody. So good afternoon. So clearly we are making some pivot. We continue to do mobile vaccination, but again, really focusing on specific communities where we know vaccine levels are lower. We also are working with the school system, and although they are working with some of the other providers, some of the retail pharmacies, we are also working with individual school districts to get the vaccine units to their schools to vaccinate the eligible adolescents. And then, of course, we are having at some of those sites and some of our permanent sites some other kind of incentives or motivators for the teens, and they seem to like the boba trucks that come in and some of the sports sponsorships that we will be providing and working with some of our professional sports teams coming up in the next few weeks. And we began working with the Medical Association and in conjunction with the California Medical Association, CMA, to really bring on board a lot of the smaller providers in the community. So all of the doctors that have their offices who up until now really haven't had access to vaccine because it's been basically utilized in our large clinics. And also there's been issues with handling and movement of vaccine, and minimum orders of vaccine, such as the Pfizer vaccine requires a lot of vaccine for a minimum order. But we are now pivoting, helping them by redistributing a lot of the vaccine, getting them onboarded to the state's system, the state's network. And we already have several pediatric practices that have signed up, and we're hoping for more of those private providers. So the next slide. And this is our latest dashboard, which I'm sure all of you have seen, and you can see the tremendous numbers that we have reached. Again, the number, just so if you had seen this maybe last week and the number looked higher on the total vaccinated, was over nearly 75% or reached 75%. It dropped down only because we added the 12 years to 15-year-old age group, and because of that, we added their total numbers to our denominator. So that added 105,000 more eligible people into our into the eligible group. So that's why, again, as we begin vaccinating that 12 to 15 group, that total percentage vaccinated with at least one dose will begin to go up again. And the total number of people who have completed the vaccine series, nearly 57%. So we're going well. If you add those 1.2 million number and the 900 plus number, you get over 2.1 million doses of vaccine. So we're moving very well. If you look at the US data, you'll see that we are far and above the rates that we see across the United States. There's always, again, as you look in the demographic numbers, there's always, again, some disparities, inequities that we continue to see in the Latinx population and some in the African American, although in the white population, they're still lagging behind our ever moving forward Asian population, which has done a tremendous job in the community getting themselves vaccinated. Next slide. And so this breaks down, as I was mentioning, the various racial and ethnic groups, and you can see we've broken them down. Again, first of all, we're showing the 12 plus, and again, that's 71.3%, but then you can see some disparities there, but of course, the Asian population is just out of sight at 88% having first doses given. The rest of the ethnic and racial minority groups are basically pretty similar along that range of high 40s to high 50s. And then the 12 to 17 and 12 to 15 groups, you can see that those are just getting started, especially the 12 to 15. Remember the 16 and 17-year-olds, April 15th, they started, and now just more recently, the 12 to 15. So we will pick up steam, hopefully. We're seeing in a lot of the sites, a lot of kids being vaccinated. I just talked to some people from Palo Alto Medical Foundation, and she was telling me that they have had loads of kids come in to be vaccinated. So perhaps some of the reporting is a little bit lagging behind, so those numbers may be a little bit showing a little lower than they actually are, but they should improve over time. But again, the disparities that we see continue to be seen also in this age group. Is there another next slide? And again, this is just some additional numbers in the age groups that we have seen. If you look again, especially look at the 50-year-olds, nearly 79, 80% total vaccinated, and the numbers are just fantastic. And then the same with the 65 years and older. So they've done a great job. Haven't completed all of their vaccines yet, but we certainly have made tremendous inroads. And as Dr. Cody mentioned, the case rates have dropped tremendously, and especially the mortality rate, which we had seen. Remember, 80% of all deaths were in 65 years and older population. Next slide. And that's basically our website that we continue to improve upon. And everyone can go there to get information on how to get a vaccine, how to get an appointment, where to drop in. All the drop-in places are on that also. And also if you want to look at our data. So I'll turn this back over to Dr. Cody.
Thanks so much, Dr. Fensterscheib. We are happy to answer any questions that you might have.
Thank you, Dr. Cody. Thank you, Dr. Fensterscheib. Let me turn to Supervisor Lee and give him the first opportunity at comments or questions. And then what I'll do is I'll have some comments and questions of my own, and then we'll go to members of the public and see if there are comments there. Supervisor Lee?
Yes, thank you. So first of all, thanks again, Dr. Cody and Dr. Fensterscheib, for the great news and the fact that we're now in yellow tier starting today. Certainly, it's been tremendous work for your team of making all this happen, delivering the vaccine very quickly. So at this point, my understanding is that we really do not have any of a short of our vaccine, and that also allowing the vaccines to be delivered to even individuals who don't live in our county. Is that correct?
We lost you there for a little bit, but I think your question was around vaccine supply, and our vaccine supply is plentiful.
Yes, that's right. Yeah, and I know previously we've been saying that we only vaccinate people who work or live here. However, I think we've relaxed that a bit now, so that let's say if we know somebody, a relative of ours that lives in, say, San Mateo County, for some reason they cannot get the vaccine, we are actually able to give them vaccine as well, right? Correct?
That is correct. Yeah.
Great. That's
Everyone
wonderful.
is welcome at our vaccine site.
Good. And very glad to hear about the Levi's, the 49ers support, or the boba trucks. Certainly these are, I won't call them gimmicks, but I think these are all incentives to get people to vaccinate, and that's really wonderful. Now, one thing, I think this is the first time I ever see these data when you break down the racial background, that right now looks like out of all the ethnicity, the white population actually has the lowest percentage of being vaccinated. They're not low, it's over 60%, which is good, but comparing to the other ethnicity, looks like this is like the group that's the lowest. And I don't believe it's a matter of access as an issue. It's more of a potentially a vaccine hesitation issue. Is that correct?
Yes. Well, I think perhaps at our next meeting we can give you more of a breakdown of those specific age groups also. But we have found that, yes, in the white population, especially in kind of the not older, senior, but the middle-aged males, white males are lagging behind a bit. Similarly with some of the younger males, but it's an interesting situation, and we're trying to figure out ways of if people are on the fence still or hesitant, how to get them in. But yeah, you're absolutely right on that observation.
Yes, because I have heard that there are quite a few younger folks in their 20s to I guess maybe early 40s even, thinking that, oh, it's okay, I won't get sick. If I get sick, it won't be that bad. I think that type of a myth is still percolating in the ether, in the media, whatnot, or social media, that cause a lot of these people having some hesitancy of thinking is not necessary. So I think as much of the fact that we're so much good news, right, that we're delivering, I think is also important to continue to advocate to those folks. So whatever it takes, whatever incentivizing you can think of doing. And by the way, I actually did pick up some Krispy Kreme donuts last night for my kids, since they all have their vaccine. So it was only one time, and I make sure they don't eat them before going to bed. But,
so the one time we're willing to suspend nutrition requirements is for vaccination.
There you go.
Yeah, we won't tell anybody.
Won't tell anybody. All right. And then the other last question I have is, since we have got so many schools reopening, and now the 12th to 15th, I do notice that my daughter's high school has now become a pop-up space next week at Wilcox High School. I just want to see, just want to commend you for your good work of reaching out to the schools, to getting various opportunities, to getting the students vaccinated in that 12 to 17 age group. But also I want to double check is, those schools pop-up locations is not only for the students, right? So if the parents want to get vaccinated, they could also get vaccinated there as well. Am I correct?
That's correct.
Great. Yeah. So the message is, students, bring your friends and bring your parents.
That's correct.
Get vaccinated. Yeah. Okay,
yeah.
Great. And that's all the questions I have. Thank you very, very much.
Thank you.
Thank you, Supervisor Lee. Let me ask just a couple of questions of the team here. A question that I want to get a certain answer to is for youngsters who have not reached the age of majority, say they're 14, 15, or 16, do they need parental consent in order to get the shot?
Yes, they do. And that consent form pops up on the website as you're scheduling the appointment.
Okay. And let me say thank you to all of you, including Dr. Smith, who I think is here with us somewhere, for the follow-up information about the 2 census tracts at Stanford. I think once we ran that to ground, we did have a clearer understanding about why the numbers appeared to be what they were. And essentially the takeaway conclusion was that we probably can't rely on the numbers from those 2 census tracts for reasons that are specific to the university circumstances. So thank you for that. I did want to ask a question about North County, the area that I represent, and the facility, particularly in Mountain View. And I have been struggling because, and my office and I have been struggling to give good advice to folks in our district, because I feel like we're getting slightly mixed messages. So I want to understand what the lay of the land is. We had heard, as Dr. Cody indicated earlier, that we had an abundance of vaccine, but a shortage of folks who were taking us up on the offer. And of course, in addition to having the vaccine, you have to have a site. And in addition to having the site, you have to have a talented group of workers there who are prepared to administer the program. I get that. But in Mountain View, when we reached out to public health to say, we were prepared to try and encourage folks to get to Rengsdorf, the site in Mountain View, we were asked not to encourage participation because apparently the site was either working at capacity or full with appointments or full with second doses. And so we said, fine. let's try that the following week. And again, the following week, which would now be last week, or this week rather, I guess, forgive me, this week, we got the same message, which was, no, we don't think we can accommodate more folks. So I'm trying to understand what's going on, particularly in the part of the county that I represent. As I say, on the one hand, I'm being told we have a surplus of vaccine and we desperately need to get people to take us up on the opportunity to get vaccinated. On the other hand, I'm being told when we try to encourage people, don't do that, we're already serving at full capacity. So can somebody help clarify that, please?
I'd be happy to. First off, I just want to remind everyone who's listening that there are many, many, many sites, many ways to access vaccines. So if you run up against full capacity at one site, there's another right behind it. So that's important to know. The specifics on the Mountain View site is that, yes, that site has been at full capacity for the last couple of weeks with second dose appointments, and then lots of new first dose appointments for the 12 to 15-year-olds that were newly eligible. And that particular site, as I understand it, the capacity is dictated a bit by the parking. It's limited by parking as well as some other factors. However, starting Monday, for all the times that the site is open, Monday through Friday, there will be drop-in availability. So the site will be able to accommodate drop-ins on all of those days. Does that help, Supervisor?
Yes, but to your point that there are other sites available, I'm looking at our webpage right now, as you know I am inclined to do during these meetings. And when I look at the drop-in sites that are identified for tomorrow, Thursday, the 20th, there are 13 sites, 11 of which are in San Jose, which, all well and good. San Jose, of course, has about half the population, slightly more, but then that leaves just two, one in Gilroy and one in Sunnyvale for the other million people who represent the other 50% of the population. So, if I have learned anything from our public health folks over the years, it's that, if we want folks to engage in certain public health behaviors that are good for us all, which in this case is getting vaccinated, we need to make it easy for them to do it. And I am concerned, frankly, that we have folks who both need to get the vaccine and who are willing to get the vaccine, if we would only make it easy for them to do that. And by not having a walk-in facility available these last few weeks, we've missed an opportunity. Anybody want to share the thinking about that?
Well, actually, I didn't share these data, but what we are seeing is the highest vaccination rates are in North County and West County. So somehow or another, folks are finding their way to a shot. It's also important to know that, we feel like as the county, we want to serve every single person and get them to a shot. And we do have a lot of partners. So in addition to our site, there are pharmacies that are offering vaccination, as well as providers. And I think that El Camino has extra capacity as well. So that would be another site for folks living in North County to access shots.
Well, I think, Dr. Smith, are you on the line, please?
I think he may not have been able to make it to Health and Hospital today. That's my understanding. I believe Miguel Marquez may be serving in his absence.
Yes,
Thank you.
That's correct. He couldn't be here today.
Mr. Marquez and Mr. Santiago, I see you both side by side on my screen, so thank you. What I'd like to do is ask for the weekly number of shots given at the Rengsdorf site in Mountain View since the facility opened, however many weeks ago that was now. I just don't recall the opening date. But my concern is that we may not be using that site to its fullest advantage. And I understand the concerns about parking, but it's a global pandemic. At some point, we need to be clear about our priorities. I think everybody has been. And I just want to make sure that if the site has the capacity and has demonstrated the capacity to provide more shots over the last couple of months, that we not scale it down. And I understood entirely what Dr. Cody was saying about the fact that folks in the North County have been getting vaccinated at high rates, and I know we're in a race to try and get to folks in other parts of the county. I want to do that. I've been supportive of it from day one, but I also know from listening to these presentations that herd immunity is about getting as close to 100% of folks as we can. And if we have folks who are maybe a little vaccine indifferent or disinterested, but who, if we made it easy for them, would show up, then we are missing an opportunity. I want us to track down that half dozen folks who are tough to reach and who have been resistant, but I also want us to get to the 100 folks who might actually show up if we told them, hey, all you have to do is drop in at a location convenient to you. And as Dr. Cody and her team know, in my district, that pocket in Mountain View is one that requires. So Mr. Marquez and Mr. Santiago, by close of business on Friday, could I get from you just the weekly number of vaccines that have been distributed from that site, so I can see whether or not we have tapered off or whether we've been continuing to provide it the same number when we were going full strength?
Yes, we can provide that information to you.
Okay, and again, look, I want to be very clear. I'm absolutely supportive of identifying communities who are under vaccinated at this point. But again, if we've got folks who we could get vaccinated more easily and push our herd immunity numbers up, that's going to keep everybody safe. And I just want to make sure we continue to pursue that. Let me go now to the clerk and see if we have folks who'd like to speak on this item.
I see no requests.
All right. Supervisor Lee, anything else you'd like to share?
No more comments. Thank you.
Okay. Then I'll go back to Dr. Cody and Dr. Fensterscheib, see if there are any last comments there.
No, thanks very much.
All right. I think we are good to go, and I look forward to bringing this conversation about the Rengsdorf site to a productive conclusion, because as I say, if we have folks who are ready, willing, and able to make their way there, if only the opportunity is presented more readily and apparently and easily, I want to make sure we're not missing them when community immunity is so essential to the success of the effort. Thank you. All right, then we need just a motion, Supervisor Lee, to receive the report.
Absolutely, so moved.
Thank you. We have a motion to receive the report on item number 5, and I will second. We have no speakers on the item, so we'll call the roll. Thank you to the clerk for that.
Vice Chairperson Lee,
Aye.
Chairperson Simitian,
Aye. Thank you very much. Motion carries 2-0. And that takes us to item number 6, which is the inpatient psychiatric facility report. And who would like to present on that item?
Hi, Supervisors. Jeff Draper from Facilities and Fleet, but I'm going to defer to Doug Koenig, our Deputy Director for Capital Programs at the Health and Hospital System.
Thank you.
Good afternoon, Supervisor Smitty and Supervisor Lee. I'd just like to point out, as you probably are aware, since our last meeting, the board did adopt our CEQA document. That's a significant milestone, which is going to allow us to commence with construction activities. I would like to make a clarification on the schedule regarding OSHPD plan review and approval. The original schedule indicated a January 22nd completion of the OSHPD review. The red bar beneath it indicates a March 22 OSHPD review approval. That doesn't represent a delay in the process. It just takes into account that the process has changed. The January 22 date reflected the traditional approach, which was the way we thought we were going to approach this. We've since been successful in negotiating with OSHPD a collaborative review process where we submit incremental packages to allow the review of the incremental package to be reviewed and approved independently, so to allow the construction contractor to get an earlier start. And that's what we've done. That collaborative process is working very well. We fully anticipate the first increment, which is the foundation and structural package, would be approved by October of this year to allow XL to begin construction in November of this year. In the meantime, we will shortly be releasing XL construction to begin the make-ready work with notice to proceed with the demolition of parking structure 3 and the excavation for the new VHSC. So you know, PS3, the parking structure has already been closed. XL construction will take over the parking structure in the beginning of next month. In the interim, county staff is removing certain devices that we'd like to save, such as the blue light security stations, security cameras, antennas, etc. But then the contractor will take over, start doing make-ready work for the actual demolition. They'll start demolishing that structure in July. Are there any questions?
Thank you, Mr. Koenig. Let me just first ask, so I take it from that, and I understand the point you're making, and I get it, that the March 2022 date does not represent a quote delay. Should that be the number listed above as well going forward, just so we have numbers that are consistent with one another?
I believe so. It would certainly eliminate the confusion.
All right. Well, thank you for that. And you know, from the beginning on this one, I've wanted us to be candid with one another about where we stand and what our challenges are, and that's why we're going through this exercise every month. Let me just say I appreciate the incremental approach that you and Oshpot are taking. You all know this far better than I, that, you know, in the world of construction, the fact that things have to be sequential sometimes also is the reason they have to be awfully darned long in terms of one thing after another, instead of doing things either concurrently or moving forward and making what progress you can on an incremental basis, as you've managed to do here. So thank you for that effort. Mr. Koenig, you mentioned the parking, and I don't know if you're the right person, but you'll recall we had some concern from staff on that campus about parking as the old structure comes down. I don't know if it's you or Mr. Draper or Mr. Santiago or Mr. Marquez, but do we feel like those issues have been satisfactorily addressed? I want to make sure we don't leave those employee issues unresolved.
I think there's still work underway, Supervisor. This is Jeff. I believe we have the number of parking stalls we need. We're making sure the security, the lighting, and the progress to get to that parking is available and it's clearer for the staff. In addition to that, we're working with the hospital administration to increase our valet services, which includes a shuttle that runs over to those parking stalls and helps people expedite their drop off and everything else like that. As well as in June, as maybe you both know, I'm sure you know, VTA is going to start a shuttle from Diridon directly to the VMC campus, which we hope will relieve some of the parking requirements there at the campus. So there's a number of issues underway, and we're still moving people off the campus. We've moved about 170 people off the campus so far, and we have another about 100 that we expect to move off the campus soon.
Okay. Well, thank you for that. I'm glad that Mr. Koenig's comment prompted me to ask Mr. Draper, because I do know we all want to get that resolved. I just want to make sure it doesn't get put on the shelf or slip through the cracks or whatever other cliche I can trot out to describe what shouldn't happen. Let me just go through my drill then as I look at the schedule that is contained in our published packet. This is page 2 of 5 in the staff report and packet page 35. Let me just ask, Mr. Draper, are we still on track to meet that schedule?
Yes, sir.
And Mr. Lorenz, are we still on track to meet that schedule?
Yes, we are, Chair Smithia.
Thank you very much. Mr. Koenig, we still on track to meet that schedule?
Yes, we are, Supervisor.
Thank you for that. Mr. Ohashi, we still on track to meet that schedule?
Yes, we are, Supervisor. Thank you.
Thank you. And Mr. Sodi, are we still on track to meet that schedule?
Yes, sir, we are.
All right. Appreciate the unanimity on that. Supervisor Lee, do you have any comments or questions, or would you just like to offer a motion to receive the report?
Yes, just a quick follow-up question regarding the parking. There was a comment last time saying that the valet wasn't available to our employees or nurses. I just want to confirm that that's already changed, right? So basically, right now the valet services is already available to them as well. Is that correct?
I believe, I may defer to Curtis Hohashi, but I believe it's still a work in progress, Supervisor, if I would say that.
Okay.
Yes, we're currently negotiating with the valet service. We think the expansion of the hours and the extension to the employee should occur sometime in early June. Right now, it's not, as Jeff said, a critical issue because there are still approximately 300 parking spaces on a daily basis that are available.
Okay, great. Yeah, so if you could get that worked out, I guess by early June, I think it would be very, very helpful. And just to keep us posted on it and making sure the impact is minimal in terms of our staff at the end of the day for our construction. There was a question or comments regarding the common pathways that's going to be shared between in the construction between the adult and the adolescents. And there will be some strict policies being in place to keep these populations separated. I just want to make sure if these policies has now been developed.
They are currently in process.
They're still in progress. Okay, so please keep us posted when that's become available. Thank you.
Will do.
And that's all the questions I have, and I'm ready to move forward to receive the report.
All right, thank you for that, Supervisor. We have a motion to receive the report, a second from Supervisor Simitian. For the record, let me check with the clerk to see if we have anyone who'd like to speak on this item from the public.
We do not.
Then let me ask the clerk to please call the roll and proceed.
Vice Chairperson Lee,
Aye.
Chairperson Simitian,
Aye. Motion carries 2-0, and that takes care of item number 6. And thank you all who are part of this effort. It's, I know, requires diligence to keep a project of this size and complexity on task and on time and all that. So thanks again. All right, that takes us to item number 7, the Allcove project. And who'd be presenting on this one?
Good afternoon, Chair Simitian and Supervisor Lee, Sherry Terrell with Behavioral Health Services Department. We have Catherine Aspiris, Moretta Juarez, and Zelia Fria Costa from our Children, Youth, and Families Division who will be presenting some updates, and we're available to answer any questions you may have.
Thank you. Why don't you go ahead and provide your initial presentation, and then I do have some questions, particularly on staffing, that I hope got communicated to you ahead of time so they don't come as a total surprise. Go right ahead.
Good afternoon, Supervisor Simitian and Supervisor Lee. I'm Catherine Spears, the Program Manager with Behavioral Health Services. For our Allcove informational report that we submitted, we include there that there is no change to our timeline for opening the sites. The sites will both be open on June 25th. The report also includes updates to our Allcove staffing and hiring plans. We have with our updated staffing, the administrative assistant with Allen Rock Counseling Center is still in the hiring process. The care coordinator with Allen Rock Counseling Center, primarily the program manager, is still in progress. We have 2 of the 3 behavioral health services clinicians already hired. One had started on Monday, May 17th. We are in the process of hiring the health services representatives. Nursing staff with Santa Clara Valley Medical will be utilizing extra help to support the beginning or the opening of the sites. We have the 4 peer support workers with Allen Rock Counseling Center that have been hired and already providing services through our virtual U program. A physician from Santa Clara Valley Medical has been is an existing physician and will be providing services at San Jose. Sanford has already hired the physician for Palo Alto site, and the credentialing is in progress. This is still pending the execution of the contract for Lucille Packard. Our program manager with behavioral health, who will be overseeing the day-to-day operations of the sites, has been hired and started on Monday, the 17th. Psychiatrists contracted with Behavioral Health Services Department through Lucille Packard. It has been identified as Dr. Steve Adelsheim, and he will be providing services pending the contract execution with Lucille Packard. and his credentialing has already been completed with Santa Clara Valley Medical. We also have a psychologist that the Behavioral Health Services Department, the Youth Advisory Group, has interviewed an applicant this past Monday, and pending the execution of the contract with Lucille Packard, they will be able to start July 1 if they move forward with this applicant. Supported Education Employment Specialist has been hired and is currently providing services through Virtual U. And then we also have a Youth Outreach Coordinator that has been hired and already working and overseeing the Youth Advisory Group. So the Psychiatry and Psychology Services, pending the contract, the execution of a contract, would be able to be provided starting July 1. That's the start of our contract with Lucille Packard. And then our primary care services would be available on June 25th at San Jose, and then July 1 at Palo Alto with the Lucille Packard position.
Thank you for, go right ahead. Forgive me, I didn't mean to interrupt.
Oh no, those were the updates that we had. Again, no changes to the site schedule. We will continue with our June 25th activation date.
Thank you. I think the team may know that I had a meeting at their request with Steve Adelsheim from Stanford and a gentleman by the name of Toby Ewing from the Mental Health Oversight Commission at the state. And they asked for the meeting because they're very excited about the work we're doing here in Santa Clara County. They're looking forward to trying to replicate it in other parts of the state. And precisely because they do want to replicate it in other parts of the state, they are anxious that when we launch successfully and that we are understood to be launching successfully. And so I think that is in part what prompted their concern about our staffing timeline. And I assured them on the one hand that I had raised these same concerns with county staff about staffing and the staffing timeline. On the other hand, I assured them that come hell or high water, we were going to open the doors on June 25th, as you all have been kind enough to assure me and my colleagues over these last couple of months. Ms. Asperis, I do want to walk through the staffing table with you one more time on page 4 of 6 and 5 of 6 in the staff report. And the reason is there may have been some changes in what you just gave me. I was trying to track as you went along. And also there are some status indicators that are a little bit ambiguous for me. I'm guessing you know exactly what they mean, but to me, I'm sitting here thinking, where does that mean we are? And please know, I understand that in our county system, you can't just snap your fingers and hire these folks. That's a process. I've observed that during my time in the county. But I'm just anxious that we launch as completely and as fully and successfully as we can on the 25th. And I want to ask you the status of these things. So if I can start on the top of page 4 of the staff report, which is packet page 42. And this is the very helpful grid that indicates ultimately we expect to end up with 9.8 full-time equivalents at San Jose and 9.8 full-time equivalents in Palo Alto. So on the administrative assistant, under FTE, it says 2.0. And then under status, it says hiring in progress. And I don't mean to be a half empty kind of guy, but hiring in progress to me means we haven't hired them yet. So how are we doing there? What's the status of those 2 positions?
So Allen Rock Counseling Center is interviewing for these positions. If the administrative assistant is not hired or ready by June 25th, we still can proceed as we will have HSRs to support the reception area and onboarding or opening and then closing of clients. So the administrative assistant for Allen Rock would not impede the opening.
And remind me what an HSR is, forgive me.
Oh, health services representative.
Okay. And so on the 25th or 26th of June, in both offices, does that mean that there will either be somebody who was hired to fill this position who has been onboarded by that time, or we will have assigned somebody who was an HSR to fill that role so that the work can be done?
I'll have to defer that to either Beretta or Zelia about the, for the HSR. If we do not have, if they are not hired, will we utilize existing staff?
Ms. Terrell, I'll let you be the air traffic controller and tell me who I should look to on my screen. Thank you.
Sure. Moretta, do you want to respond to that one?
Sure. I'm sure that we will be able to provide, clerical support on that day.
Okay. And then, thank you for that. And then the next positions are care coordinators. And it says that we need 2 folks to fill those roles, presumably 1 at each site. And then under status, it says 1 of 2 hired, which again, as a matter of concern, I'm thinking, okay, does that mean that one of those folks who is described as a team lead has yet to be hired for one of our 2 sites?
The team lead has been hired and has been already onboarded with Allen Rock Counseling Center. The program manager that will oversee the lead, team lead, and the peer support workers have not yet been hired, but they have been.
I'm sorry, go ahead.
Oh, they have gone through an interviewing process with the youth advisory group.
So it says here under care coordinator, includes team lead and program manager. Does that mean there are 2 people who are called care coordinators, but one of them is a team lead and one of them is a program manager?
So originally our proposal for staffing was supposed to have 2 care coordinators, but the request with our partners at Allen Rock Counseling Center was to change the staffing, but the function of care coordination will still happen with the team lead and the program manager.
Okay, and Mrs. Spears, forgive me if I keep pressing this point, but it says here we need 2 people, but it says we've only hired 1 of those 2 people. Is that accurate?
Yes.
Okay. And so you'll forgive me, but the reason I got anxious is on the first 2 positions, administrative assistant, care coordinator, that's a total of 4 people, 3 of whom have not yet been hired, according to my understanding.
Mm-hmm.
That takes us to the next, which is the clinician. And there it says we need 3 people. And over under status, it says that 2 of 3 have been hired. One of them will start, was to have started a couple days ago, and one of whom is supposed to start mid-June. But I read that as meaning that we're 1 person short still. Is that accurate?
That is accurate. The clinician that started on May 17th will be the clinician at San Jose. The clinician starting on June 14 will be the clinician at Palo Alto.
Okay. And then under health services representatives, it says HSRs, and it says 2.0 is the FTE requirement there. But under status, it says recruitment in progress, which I take to mean we haven't yet hired those folks. Has there been a development there, or are we still in fact looking to hire but haven't yet hired those 2 people?
We are still looking to hire. We've gone through 2 rounds of recruitment and we're not able to provide or to complete, or they did not accept an offer.
Got it. Thank you. So now I'm just going to pause again and say, Mr. Rao, I'm looking at the first 4 identified sets of positions where we needed 2, 4, 6, 9. And by my count, we're down 6 out of 9 people who we don't have hires for yet. So that's a source of concern. Then we get to the licensed vocational nurse and clinician, nurse 3. And here again, it says 2.0, but status it says is TBD by VMC, which again, I read as saying it's to be determined, which is to say we have not yet identified the 2 people for those slots. Is that correct?
Supervisor Simidian, Chair Simidian, this is Paul Lorenz, and I am working with the Behavioral Health Department on this project. Obviously, my team is, and we understand the importance of this project So from a medical care and clinical standpoint, we are assigning experienced staff until which time we can fill the vacant positions.
And Mr. Lorenz, thank you. I'm going to press on you as you knew I would when you leaned in. So thank you for leaning
Yes.
in. Does that mean that on June the 25th, we will have found 2 capable folks to fill those 2 slots to start the program off, to launch it?
We will have, yes, capable folks meeting the needs of that service at both Allcove locations.
Okay. Mrs. Paris, just so you know, I see it, peer support workers, 4 of 4 hired. So great, thank you. Then on the physician, and maybe this is Mr. Lorenz again, I see a 0.8 identified as the FTE for both sites. And again, on San Jose, it says to be determined by VMC, and Palo Alto, it says hired, but the credentialing is in progress. So that makes me think that we're not yet able to say we have either the San Jose or Palo Alto folks unless there's been a change there.
Right, Supervisor, we have identified the VMC physician for the San Jose location, and he is available and ready to start. With respect to the Palo Alto location, we do not anticipate there to be any challenges relative to the credentialing, and we expect that he will be able to start as scheduled.
Got it. The program manager 2 seems to be squared away, 1 position, hired, start date, good. The psychiatrist 0.4 FTE says hired, but credentialing completed. So I take it that that's all good. Same with the supported education employment specialist, hired, youth outreach coordinator, hired. But that still leaves us with, 8, 9 folks out of the almost 20 that seem a little loose. Mr. Lorenz, am I reading that right?
Those numbers seem to be correct, yes.
Okay. Thank you, Mrs. Paris. And Mr. Rao, am I reading those numbers right?
Yes, that's correct.
Okay. How optimistic can we reasonably be? I'm not asking, to be, hoping, but not realistic, that we're going to get a number of those slots filled between now and June 25th.
We are actively pursuing all of our recruitment options and are pressing as hard as we can to get those positions filled. I think we can continue to provide updates on our active recruitments and where we stand. As Catherine mentioned, a couple of recruitments have been pursued for which we were unable to secure applicants. However, we continue to pursue these on a daily basis and will continue to push towards June 25th with as optimal staffing as we are able to open the doors and provide the services.
All right. Well, thank you for that. I'm going to, just as an individual board member, ask that Mr. Lorenz and Mr. Rao and Mr. Santiago and Dr. Smith, if you could pass the word along. Ms. Marquez, as I say, all push to try and make sure that when we open this, we are as close to fully functional as we possibly can be. I know people have been working on this in our organization for 5.5 years. So, no one wants to open an empty box. The good news is we clearly are not going to open an empty box. But as I say, we don't want to be in a position where people think we overpromised and underdelivered. I take some solace from the fact that this will, in fact, give us some time for the youth advisory group to give us their thinking about what's needed and what kind of services will be helpful. But Mr. Marquez, if I could get you to lean in here just for a moment, since you're our Chief Operating Officer and here in Dr. Smith's stead, I just want to be clear in my exhortation that we need to stay on this, and it sounds very clearly like the work will not be done the day we open up the doors. There'll still be work to do. Yes?
Yes, and as Mr. Lorenz said, we understand the importance of getting proper staffing there, and we'll have the right people there so the services can start, but we'll still have more hiring to do. But of the 8 or 9 positions you mentioned, the good news to me is that it sounds like we're well underway in hiring those folks. And so we'll keep pushing and pressing to make sure that we get those hirings done expeditiously, and so we don't put the operations in jeopardy in any way.
Thank you. And Mr. Marquez, could we get an update on the 2-page staffing grid on Friday, the 18th of June, so a week before the event? We're all clear about where things stand as of that date as we head into the week of the opening.
Yes, we can do that.
Thank you very much. And I did think the grid was very helpful, very easy to parse, and even when the news wasn't what we might hope it to be, at least it was clear where things stood, and particularly clear with the help of staff. So thank you to staff for making that happen. That is all I have. Supervisor Lee, comments or questions before we go to the public?
Yes, thank you. Okay, here we go. Now we can see myself. Can you hear me okay?
Yes, and for a minute we had 2 of you. I thought I was going to get stereophonic Otto Lee. So there you go.
There we go. All right. Yes, good afternoon. When I look at the staffing positions of the physicians, psychiatrists, and psychologists, we look like those are all under 1 FTE. As a matter of fact, it's only 0.4 for some of them. So I'm just trying to find out, is that really enough? And maybe is this something that we need to potentially increase in the future?
Thank you for your question, Supervisor Lee. Following the initial implementation of the program, we will begin reviewing the data of the consumers served, as well as what the community trends are and what the needs are for this population. And then we will look to present this information to our executive team and look into our advisors with the community consortium and our youth advisory group to receive feedback about how we will expand and refine staffing if needed.
Great, thank you. Yeah, I would love to see if there's actually additional need. We certainly don't want to limit based on the initial allocation of those personnel. The community consortium, in this case, I believe is led by the Alum Rock Counseling Center, is playing a very important role during the Allcove implementation. Would you be able to provide us some type of update on this community involvement, or community consortium's involvement up to this point?
Yes, our community consortium thus far has met 3 times. So our initial meeting was really to orient them to the Allcove program, the youth advisory group, and the Allcove implementation team. And then we also met with them additionally the 2nd and 3rd time to go over what services and how we would want to look into expanding services at the sites and what are the needs of the community and needs of the young people that we expect to serve. We also have connected with the individual consortium members to see how we can engage with the community. So in each community consortium, we have a community person or has lived experience or has experience or who is part of the community. And we've asked how we can start engaging with the community, letting them know and introducing ourselves to the community. So we have met with Spartan Keys Association and looking into joining their neighborhood watch. And then we have our June meeting that will be happening actually on site at both Palo Alto and San Jose, where we will tour the site and provide them kind of a meet and greet with each other, since we have not done it, we haven't done it in person. So they will be here at each site to tour the site and receive some Allcove goodies, and then also look into discussing outreach activities and planning for our introduction to the community.
Great, thank you. On the question regarding the electronic health record, I believe we have 3 types of records here. We have the My Avatar, the Welligent, and also the Health Link, right? So want to find out if there is some type of information sharing by the staff about these health records after the pre-admit process, and will these information be kept separate from each other thereafter?
That's a great question. So we are working diligently with County Council on Compliance and our Behavioral Health Services team and the implementation group to discuss the workflow. And at the moment a youth comes into the center, they would be asked to complete an ROI, release of information. And that way we can share information between the different providers and the different departments. But for the reason of care coordination, primarily, we would be working with the youth and coordinating care with Valley Medical, with our psychiatry, psychology, and behavioral health services. For non-clinical treatment, we can definitely work on coordinating services with them and sharing information if they have signed the ROI. And again, there's these different electronic health records that we will have, but in the front facing, the youth will not experience the complexity of our EHR systems. We have a process in place where all of the youth that come to the site will be entered into our avatar system as a pre-admit, and we will collect demographics and be able to report out on the number of served, their reason for referral, and where they're being referred to. If they are going to become a behavioral health client, they will be admitted into Avatar. If they are seen with the medical group, they will be opened into HealthLink. If they receive case management, they will be opened in Allen Rock's Wellagent system. But the idea is that we would be sharing like the screening tools and demographics, minimum data set to get them to ensure that the youth don't have to see the same things over and over.
Right, exactly. Yeah, I think a lot of times people are very tired of having to re-enter data 3 times, right? So we certainly want to avoid those type of situations. And then with these different type of services, right? Are they going to be just mainly co-located at the Allcove, or do you think they actually will become integrated services given?
The services would be integrated. As far as our like data systems, we had not planned to interface with each of the different systems, and of course HealthLink and Avatar's accounting system, but we would not be interfacing with Wellagent. We still need to look into what the Data Cove system will be that Stanford will be implementing, and seeing how that system and that process would work. But in terms of like integrating care, we plan to also work as a multidisciplinary team to coordinate care with everybody in the team, and having weekly huddles and discussions about specific cases that we may want to refer internally to each other.
Great. And that's all the questions I have. Thank you.
Thank you.
Thank you. Let me check with the clerk to see if we have speakers on this item.
We do not.
Then let me turn to Supervisor Lee and ask if he's prepared to make a motion to receive the report on item number 7, the Allcove item we have just been discussing.
Thank you. So moved.
Thank you. Motion by Lee, second by Simidian. We'll ask the clerk to call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. All right, the motion carries unanimously. Thank you very much, Mr. Rao. Thanks to you and your team. And let me just say, I know it's not that much fun to come to one of these meetings and have supervisors ask you question after question and after question. But the hope and expectation is that it helps get us to a better place in terms of the service we provide. So I appreciate your hanging in there on these questions.
Absolutely, Supervisor. Thank you very much.
Thank you. All right, that takes us to item number 8, and that is the report that we have, and it is on the Asian and Pacific Islander Health Assessment Update, specifically in reference to the Asian and Pacific Islander Health Worker Program. Let me ask who's going to be presenting on this item. This is item number 8.
Thank you, Supervisor Simidian. I'm joined by Rhonda McClinton Brown. We don't have a formal presentation, but Rhonda is on and can answer questions.
All right, thank you. Let me ask Supervisor Lee if you've got questions, and then I have sort of a global question that I want to ask. So I'm going to save it for last. Supervisor Lee, to you, sir.
Thank you. We see that the services being provided through the community health worker model, such as removing the barriers to access care and providing the essential linkage among the different health services, Could you provide a bit more detail how these services look like with the different communities, especially like the Vietnamese or the Filipino and the South Asian Indian populations?
Yes, thank you. This is from Supervisor Lee. I had a really hard time hearing you. I think you asked me to describe the services for the three populations and how that will be implemented.
Yes, exactly.
Okay.
Correct.
Yeah, thank you for that. We're not quite there yet, but let me just give you kind of a picture of how that might look. So the first step, of course, was identifying the three populations. The next step, which is what we reported on today, is Aki is implementing training of all of the community health workers, in which they have retained. The plan for the services is to go back to the health assessment implementation plan, the priorities and recommendations. And they're in not the last meeting, but the meeting before, the Health and Hospital Committee meeting 2 meetings ago, when I did the comprehensive report on the Asian Pacific Islander. One of the attachments was the priority area matrix that was developed by the broad community meetings that took place, where each of the subgroups actually prioritized and defined the areas of services that they felt were priorities within that community group. So the plan is that Aki will reach back to the community to confirm that those priorities that they established for services are still valid and still needed at this point in time. And in that event, then they will begin to implement services in those topic areas, providing resources, connecting people to services, providing education, providing outreach. Globally, across all community health worker programs, the community health workers will be providing education on COVID-related items, issues. They will be trained on COVID-related issues and vaccines. They all will be receiving some type of education about intimate partner violence and universal education. As the directive from the Board of Supervisors, when we did this initial report, was to integrate behavioral health and intimate partner, Office of Gender and Based Violence, intimate partner violence, universal education. So they will be trained on universal education. They will also be trained on behavioral health assessments universally. Once all of the community health workers are trained in implementing those services, then we will reach out and decide if there's other specific chronic diseases or other risk assessments and referral services in other topic areas, such as other chronic diseases and things like that, that the community health workers may want to be trained on to implement. But that would be kind of a third phase in their training and implementation. So does that answer your question?
No, I think it does, and I think it's very focused, especially since the report shows the group right among the Asian populations. Once you do the data segregation, you really can see that the Asian is such a great group, big group, and the Vietnamese and Filipinos or some of these communities clearly have greater burden and some adverse health outcomes that we are learning, right? So we want to make sure that we be able to do more focused outreach in language, of course, to these communities on these specific issues that we're identifying. So thank you very much.
Yes, correct. And the idea in the model that was originally presented to the board is that there would be community action planning. So the idea is to be responsive to what each subgroup has identified as their priority. So we will build out those services that are unique to the specific population, even though there will be some cross-cutting services amongst all of them, such as COVID and universal education for intimate partner violence and such.
Right. Yes. All right. Thank you. And that's all the questions I have.
Thank you, Supervisor Lee and Ms. McClendon-Brown and/or Dr. Cody. I have a couple of just check-in items. I want to make sure that my understanding is correct, that we do anticipate that going into the next fiscal year, meaning, after July 1st, we will move beyond those first 3 populations and be on to another 4 subsets of the Asian American and Pacific Islander population, including the Chinese, Korean, Japanese, and Pacific Islander subsets. Yes?
Yes, that is correct.
And my recollection is that there's about $400,000 in the budget to help us with this next year. Yes?
That is correct.
Okay, just want to make sure that the things were still on the track I anticipated.
We are moving forward.
And Ms. McClinton-Brown and Dr. Cody, we had some conversation in my office today in preparation for the meeting, and I just wanted to share it with you because, you know, I know sometimes staff walk away from these conversations like scratching their heads saying, now, what is it that they want? What is it they're hoping for? What is it they're expecting? And you know, the way I sometimes frame this question is, if we do this work well, how will the world be a better place? All right. So, you know, what does success look like if we achieve it? And, you know, why did we undertake this effort? I mean, it's been a long haul going back to the Asian health disparities assessment that you all did at my request with support from then Supervisor Cortese. And then the follow-up after that was to work with you all to say, all right, how do we make that information relevant and turn it into something tangible out in the community? And my hope and expectation is that this community health worker model is going to do essentially 3 things. That it's going to connect folks with healthcare services that they need, perhaps on an acute care basis, which previously they have not received because there were language issues or cultural competency issues, or simply a daunting healthcare system that's too complex for a lot of folks to navigate. And that's number 1. Number 2, that we will, by engaging folks, you know, where they are out in the community, we'll have an opportunity to pursue some preventive strategies that otherwise would be missed altogether. And number 3, that by the nature of the job description, folks will, the community health workers will be able to help with what might look like social service issues to somebody else. But when we talk about housing and nutrition, for example, they clearly have health impacts. So for me, that's the 1, 2, 3 of it that has been guiding my thinking on this now for this last number of years, and what I'm hoping to see accomplished once we dot our I's, cross our T's, put the money in the budget, and go through the contracting and hiring process. And let me just ask, does that sound consistent with what you all are envisioning? And
Supervisor Simeon, yes, thank you for summarizing that. That is exactly how we're envisioning it. Let me just make sure that that we're seeing the same thing in the third one. I would just add a slight addition to your third one, in that we are building a workforce, also ethnically focused workforce that is equipped with skills and capacity to address community needs as well. I would kind of lump that into your third one, which is really critical because, you know, one of the contributing factors in health disparities is we don't have a workforce with competency skills to address the unique needs of specific populations. In the Asian Pacific Islander community, it's even further challenging because we have so many subpopulation groups. So I think another outcome from this is that we're really building community capacity and proficiency through a workforce development strategy that's going to allow us to pivot and to expand and broaden our abilities to be responsive to the health needs of those specific, of each of these specific communities.
Ms. McClinton-Brown, thank you. That's helpful, and it's, I think, important enough and significant enough that I'm going to elevate it to a 4th point or benefit, not make it just part of the 3rd observation I was sharing. I think, thank you. It's helpful for you to underscore the importance of that as an additional standalone, but obviously related benefit of the exercise and the effort. So thank you for that. All right. Anything else from our public health team? Supervisor Lee, anything else from you?
No further question.
Can we get a motion to receive the report?
Yes, so moved, please.
All right, and I will second. Let me check with the clerk to see if we have any members of the public who'd like to speak on this item.
We do not.
Then we'll call the roll, please.
Vice Chairperson Lee,
Aye.
Chairperson Simidian,
Aye. And that motion carries unanimously. Thank you all again. That takes us to item number 9, which is the subsidized medication program update report. And Mr. Lorenz, I see your name here. Would you like to present, or should we be turning to one of your team?
Thank you, Chair Smitty. Just a few brief comments. I have to say that we're very pleased and excited to bring this report back to you, both in terms of updating you on the pilot program, the research program relative to the medication assistance program, in which we actually have achieved the enrollment of 300 individuals, which was our target. That, of course, was a concern brought forward at the last meeting. And I think the staff have done an incredible job in kind of retuning the program and making sure that we hit our targets. The second part of the report, which Dr. Nari Singh will be able to provide an update on, is our recommendation on a long-term sustainable program around medication adherence and assistance. So at this point, with your approval, I will turn it over to Dr. Singh.
Thank you, although as you know, I'm likely to come back to you as well, Mr. Lorenz. Thanks.
Yes, sir.
Dr. Singh?
Good afternoon, Supervisor Simidian and Supervisor Lee. I have a very short presentation that I would like to make. So I'm going to share my screen. So please let me know if and when you can see the screen.
Yes, we can see it.
Thank you. So we are starting this program, and we are calling it Medication Adherence Assistance Program. The core of the program is to help patients improve their adherence to the medications. The program overview is really to remove barriers for any financial needs that the residents of Santa Clara County may have. We also call this the forgotten middle or the missing middle residents who may have a financial need but are not at a level where they can get other governmental programs. So this particular program will be focused on the missing middle. Any county resident can apply for this program. The 3 drug classes of the high cost medications that will be covered by the program are the insulins, the asthma inhalers, and the EpiPen or the epinephrine autoinjectors. As I mentioned before, the core of the program is to improve adherence and provide education to the patients so that at the end of the day, the patients can improve their outcomes. And when patients have better outcomes, overall, the healthcare cost decreases. So it's a win-win for both the patient and the health systems. Some details of the medication adherence assistance program are that the prescription can be filled at any pharmacy in Santa Clara County. The program is going to be a grant-based program, which again is open to all residents of Santa Clara County. The grant amount is going to be based upon the disease state that the patient has, the financial need that patient has, and the amount of participation the patient is willing to spend time and perform certain activities within the program itself. The patients can maximize the grant by improving their medication adherence and by participating in those adherence activities such that their outcomes are better both for the patients and for the health system. From a funding standpoint, we are recommending that we start the program with about $1 million for the fiscal year 22. Once we get more experience with both the patient population, their participation in the program, and the outcomes that we receive, we can then reassess the funding annually thereafter. I will take any questions or answer any other specifics.
Thank you, Dr. Singh, and thank you, Mr. Lorenz. A couple of comments and questions. The comment I want to make is in connection with the bottom of page 1 and the top of page 2 in the staff report dated May 19th, 2021. This is the paragraph that begins with the phrase, "The pharmacy team therefore secured IRB approval to expand the target population for this pilot." And what I want to say, and it's rare that I do this, but I want to compliment whoever wrote this paragraph because I could actually understand very crisply the 1, 2, 3, 4, 5 things that somebody said, okay, we're not reaching enough people. We'd like to reach more people. What are we going to have to do to reach those more people? And the answer was, we're going to have to do these 5 things. And they are very crisply summarized. So thank you for the crispness with which the explanation is provided. Thank you even more importantly for actually acting on all 5 of those possible paths towards greater participation. You know how disappointed I was when we had such modest numbers the last time, and I'm much more pleased than I was disappointed the last time for what it's worth at the progress that we've been able to make. So thank you. I know that doesn't happen without some concerted effort, and it's clear that people stepped up and tried to figure out how to do it. Again, a comment, Dr. Singh and Mr. Lorenz, I appreciate the focus on the missing middle. And I want to be very clear, Dr. Singh, we're not talking about giving free medical devices to rich people. We're talking about people who are people of modest means, who are seeing these life essential drugs priced at a level that can literally force them into bankruptcy. I'm not being overly dramatic, I think. And as I understand the way the program is now structured, you've said anybody is theoretically eligible, and you can go to any pharmacy in the county, not just a county pharmacy. And to the extent that we have resource constraints, meaning, limited amount of money and a limited number of folks who can participate, the folks who have the greatest need and who do the best on medication adherence are going to be the folks who get the opportunity to participate. And so that could vary from year to year, but within the limits of our financial capacity, we'll do a need assessment. And but I think this is important because I worry sometimes that as a safety net organization, we almost end up putting ourselves in a position where people have to be driven into really indigent circumstances before we can step up and help. And part of the reason I brought this referral to our board, I think it was beginning of last year, is because I wanted to see if we could avoid driving people to the brink of bankruptcy by virtue of obviating the high costs here. Let me just ask a couple of questions for either Dr. Singh or Mr. Lorenz. In my initial referral, of course, I talked about the desire to see some of this in the North County, and staff came back and said we'd like an opportunity to focus in other parts of the county first, and we'll get back to you on North County. So this is the moment when I'm looking you in the eyes, Dr. Singh, and saying, hey, how about North County? Yeah, this is the opportunity to get back. Mr. Lorenz, thoughts?
Supervisor, I have to say that through this process, we've learned a lot. And I think where we ended up is with a program that is truly countywide, and we'll be able to serve the residents in the North County, the South County, anywhere within Santa Clara County. And so I think we ended up in a really good place relative to making sure that those people that you just described that are on the fringes can get the medication they need. And hopefully we can achieve the outcomes that the medications are intended for.
And thank you, Mr. Lorenz. And let me ask both you and Dr. Singh, I think there is a role here that any of us could play if we had the inclination, which is to spread the word out into the wider community if this is not going to be limited to our typical patient population. So with your permission, I'll have my office reach out and talk to your team about how we might constructively partner in outreach efforts in the area. And I'm thinking, I know you and your team have been working to bring pharmacy services to Mountain View at that Planned Parenthood site. Is that a venue where we might be able to make a concerted effort? It seems to me an ideal location for people who, as you describe them, are perhaps just on the fringe of financial stability for these kinds of services.
Absolutely, Supervisor Simitian. That pharmacy is in the right place where patients can easily access it, and we will staff it in a way where this type of a program can be easily administered from there as well.
All right, good to hear. We had talked about this initially as a pilot program, and I guess my question is, are we still in the pilot? Have we moved past the pilot? Where are we? Or have we said, you know what, whatever we call it, we now have enough experience to know we want to keep doing it? Where are we in that process?
So Supervisor, you had mentioned that in your referral that one of the requirement was we should have a program that is publishable. So we still have the study that is currently ongoing, which is IRB approved. That study is not complete yet. And that study will be the publishable study, which is the pilot. And that will take its own course. We have completed enrollment, and we need 6 months after enrollment to collect the data, analyze the data, and then publish the results. Parallel to that, we are proposing this particular program because from the enrollment itself, we have enough experience to know that these are the things the patients are looking for. And so the study is ongoing, but we also have a program for your consideration along with the study.
Okay, so do we think we are about 6 months away from that study's completion, Dr. Singh?
About 5 months away.
All right, thank you. That was a very helpful explanation. I was trying to figure out where we were in the journey, if you will, to program realization. And then, Mr. Lorenz, my recollection is that we have $1 million in the budget for this program in the coming fiscal year. Am I remembering that correctly?
That is correct, Supervisor.
And I wanted to get a sense for what would that allow us to do? How many folks does that allow us to serve? Does that mean we're sort of hanging in there with about 300 folks for the next fiscal year? Is it a little less than that, a little more than that? I don't really have a clear enough understanding right at this moment to sort of figure that out for myself. That's why I'm asking you.
So Nari and the team have run some preliminary numbers based on our experience around the cost of the medication and the type of disease and the utilization. And at this point in time, with this preliminary information, we're looking at possibly serving up to 1,000 individuals with that $1 million. Obviously, needless to say, as the program unfolds, we'll learn a lot more. But that is the number that we feel like that we can support.
All right. Well, thank you for that. I know that the expectation is that we will continue to provide the program and services and then assess the utilization and the need in coming fiscal years, coming budgets. And so we'll be checking in with you from time to time on that. And, if the program performs as I hope it will, and as it seems to so far, and again, thank you for the literally half a dozen or 5 or 6 at least changes to make it function more robustly. I have to tell the county executive he may see me again on this one where I'm hoping we can do a little bit more. And I'm saying that in part because I know Mr. Santiago and Mr. Marquez and our budget team are all on the line as well. And I just sort of want to be forthright about the fact that I'm hoping this is a worthy effort that we can expand to benefit even more people. Thank you. All right, let me see if Supervisor Lee has questions.
Yeah, thank you, Supervisor Wasserman. Supervisor Simitian, sorry about that. One issue, first of all, I just want to say that this is such an important program, and it's really unfortunate to know that there are these high deductible health plans that's causing a lot of potential financial pain to our community. As we know, we've been so much working on getting more people access of health insurance. So these are individuals who actually are in some type of health insurance plan, but because of the high deductible, is basically making the choosing to whether pay for medication or food, which to me is frankly, in such a civilized community as rich as we are, is really unconscionable. So that being said, I want to make sure that the application process is something that is easy, and also in terms of the access, to make sure that we have various in-language access being made available. So I'm just confirming that what type of in-language accessibility right now is being provided in the application process.
So supposedly, currently we are in the study phase, and in the study phase, we provide care in the three primary languages that the health system uses, which is English, Vietnamese, and Spanish. But once we go into the enrollment phase or the program phase itself, so at a minimum, we will have these three languages. And I know that more recently, we have started adding Chinese as our fourth language. So the program will be administered at least in these four languages.
Great. And of course, we need to get the word out in language as well in the ethnic media, so that this will be widely publicized. I think that's great. Now, this is only a program for adults. So my question is, how are we able to also potentially expand that to those who are children who have these needs as well?
So same thing, as I said before, which is as we get more experience with this program, and we get better knowledge of the types of patients and the cost of prescriptions, I think we will be in a much better shape of refining the program and including the other patient population.
Great. And please do come back to us. Obviously, we expand this program. I would imagine the $1 million probably won't cover the cost. So please let us know. And this is certainly such an important effort that our county, is being the social safety net that who we are, we really need to be able to provide that to many of our low and medium income residents. So thank you very much for your great effort.
You're welcome.
Thank you, Supervisor Lee. Let me see, check in with our clerk. Do we have members of the public who would like to speak to this item?
We do not.
Then I will ask for a motion to receive the report from Supervisor Lee.
And yes, so moved to receive the report.
Motion by Lee, second by Simidian. Call the roll, please.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. And thank you again to Dr. Singh and to Mr. Lorenz and to the whole team and to whoever wrote that paragraph that I grabbed onto, because it was really, okay, here are the 5 things we did. Appreciate it. All right, that takes us to the next item, item number 10, which is the report from our Emergency Medical Services Agency regarding the EMS 2224 Ambulance Services Request for Proposals process, which is a mouthful. So who's going to start?
Good afternoon, Supervisor Lee and Chairman Simidian, Jackie Lowther, the EMS Director. And I don't have a formal presentation, but I do have a couple of salient points that I can review, and then we are open for questions. Just a brief history. Way back in June of 2019, the EMS agency did convene an introductory meeting with key stakeholders to sort of explore and define the options and structure of the EMS system in Santa Clara County after the non-exclusive 911 EMS ambulance transport agreement was to end in 2022. The committee last met in March of 2020, at which time a draft scope of work for a request for proposal had been developed. Due to the events that occurred way back in 2020, pandemic and fire and so forth, it was determined it was going to be necessary to extend the ambulance service contract, which is now set to expire in 2024. The EMS agency convened this group in in March of 2021. And what we did is, as a group, we decided to make a decision on an informal competitive procurement. And this process to get a consultant to provide assistance with organizing, convening, and facilitating these meetings. And they're going to help us collect and disseminate information related to the county's emergency ambulance service area. Our first meeting was in March, and this ICP was released on April 13th and should be conducted and concluded by June. A second ICP will be released probably the end of June or early July, and this one will be for the financial model to develop and conduct analysis around the costs surrounding an RFP. A new timeline will be developed probably by the end of summer, early fall for y'all to take a look at. And myself and Dr. Miller are here to answer any questions that you might have on our process or the committee, our EMS stakeholder group.
Thank you very much. Let me go to Supervisor Lee, and then I have some questions. I'm going to ask you and your team, Ms. Lowther, to sort of demystify, de-jargonify, bottom line, plain English. I can trot out a few more cliches here in a minute, but first let me go to Supervisor Lee and see what he has in the way of questions or comments.
Yes, thank you. Ms. Lowther, the question I have is regarding the current provider. On the background, it says that the county and rural metro entered into the EMS agreement initially back in 2010. And I believe there were some transitions that took place in the middle. I didn't really see it on the report specifically, but maybe you could highlight to me a little bit more about the change or the different provider we've been using for the service.
Back in 2010, I'm sorry, Supervisor.
Right. Yeah, the background on page 2 of 3 in the packet, page 54, talks about the back in December 2010 that the county and rural metro entered into original EMS agreement to provide the advanced life support for the county. And anyway, so has there been a change of a provider of the service? It's always been rural metro is still doing that work for us?
No, what happened in way back then, they were rural metro, and they were AMR bought them, and so we still call them rural metro doing business as AMR.
Okay.
So it's basically the same company that was bought by AMR. So the contract actually has rural metro of California.
Okay, gotcha.
Is that the question?
Yeah, yes, right, yeah, because that's why I was a bit confused, because I did see AMR's name as well. So that's why I'm surprised to see the rural metro and the AMR, because I believe previously those were competing entities.
Right.
Contract. And so there was, I don't know, did one get bankrupt or something like that? So it got bought out. So I just want again, there was a while, this is a long time ago. I don't have very good memory, just to see if you could help refresh my memory of what happened. Yeah.
Right. We'll have to catch you up on all of that, because the history is long.
Indeed. Okay. All right. So at this point, basically, it's until 2024, we're still pretty much good to go. But after 24, this whole stakeholder is getting together to get ready for the bidding to have services to start in 2024. Correct?
Right.
Okay, good. Thank you.
Thank you, Supervisor. And Ms. Lowther, you know, I've been on the Health Committee now for 8 years. And of course, we've had a lot of conversation on this topic. So let me just recap. There was a competition back in 2010 or 11. It was a spirited competition. It was a somewhat controversial competition. Ultimately, rural metro prevailed and began providing services in 2011. which Supervisor Lee means that they were on the job before I arrived on the Board of Supervisors for my second go around. Ms. Lowther, do I have it right so far?
Yes, sir.
And then I think it was in 2015, but the years blend together, that AMR acquired Rural Metro and their former competitor became their property. Is that a fair summary?
It's a fair summary.
Okay. And what that means, and this has been a source of some concern and just administrative challenge and oversight challenge in my view, is that we are working with a contract which has been amended repeatedly for a variety of reasons. But Ms. Lowther, I think we're on our, does it say 8th Amendment, something like that at this point?
Yes, sir.
Yeah. So, and you know, that's not an intrinsically bad thing, I guess. It just means that we've sort of patched and repaired and cobbled it together and added a new provision and changed terms, and without what I would call a sort of comprehensive or holistic reassessment. Again, I don't say that critically, but I think that's an accurate assessment. Yes, ma'am?
Yes.
Okay. And so now it's extended through 2024, and we need to figure out what we're going to do before we get to 2024 when the thing expires again. Is that where we are?
That's where we are.
Okay. And you've been meeting with a bunch of stakeholders to make sure that everybody has a chance to put their 2 cents in about how we ought to do that. Yes?
Yes.
Okay. And there's a challenge here as to how many private sector entities might actually compete, and whether or not we'll actually have a what I'd call a lively, vigorous, real competition between and among private sector applicants. Yes?
Yes.
Okay. I mean, I hope, you know, I think it's in everyone's interest for there to be lots of competition, but I know that the market has been to some extent consolidated and that the number of players is diminished, and that's a source of concern. And we've looked at some other possibilities various board members have suggested. Folks in our local fire departments have talked about providing a public option. Ms. Lowther, I think it's fair to say that Dr. Smith has been skeptical of that model. Is that a fair summary? I know you and I can't speak for him, but I think that's a fair summary.
Public or private option?
The public option with the fire departments.
Yes.
Okay. And so could you revisit, just sort of bottom line, just the high points? So, you know, like, so what happens next? How do we end up with a new contract by 2024, since, you know, we're in the beginning of 2021 and 2024 is not that far away?
By having our, what we're looking for is a facilitator to help us with the group, and a financial facilitator to look at the financials, so we can look at all aspects of this, both public and private, because there are many options out there. We have 4 very good options to look at, and combining all of those, it really is going to be interesting. We really have time to get out a very good RFP over the next 3 years, and we have great stakeholders on our team representing all facets of the county.
Great. And the reason we're having all this stakeholder engagement is so that we have the maximum number of options available for our board and our county, the maximum amount of competition of ideas and organizations. And so no one can complain at the end of the exercise that we didn't tell them what was going on and weren't wholly transparent. Is that fair? I know I keep putting words in your mouth, but you push back if I put the wrong words in.
No, and Mr. Marquez is also on the line. And so far, what we really want this to be fair, open, transparent for all of our community, so that we have a fair, just, and safe service for all of our community members.
All right, let me go to Mr. Marquez, because he's actually figured out how to raise his hand using the technology. Mr. Marquez?
Indeed, it only took me a little more than a year to figure that part out. But Yeah, a couple points I wanted to make is along with the transparent process, it's going to be a very inclusive process. We've been working really hard, bringing all the relevant stakeholders together. As you saw in the ledge file, having a process to bring on a facilitator because the county itself is a very important stakeholder, and we didn't want to feel like we were somehow able to facilitate as well as somebody who's professional at it and sort of independent, if you will. But I also thought as part of the history, I don't remember the dates because I'm, it's been so hard lately to keep years in mind, but one year, maybe 2017, 2018, we did an RFP process. And I think a lot of times that RFP process we went through is forgotten about because we went through the process. We had only one vendor apply. The proposal we received was not compliant with the RFP requirements. And so we had to not make an award. But we did go through a process and it was unsuccessful. So we have that in our history and we want to make sure we don't repeat that and that we do everything possible to really explore all of the possibilities. And that's what I wanted to end with is, I'm not sure I heard correctly, but I want to be clear that from the county's perspective, all options are on the table. That's what the stakeholder process is for. That includes the public option, that includes private providers, a public-private. We want to be creative and want to do whatever's in the best interest of our community for all the stakeholders. And so I do think that there are some complexities that come with the public option. But we are used to dealing with complexity and we have the right group at the table. We have the right process in place. And I feel optimistic that we will craft an outcome that's going to be beneficial to all involved. Thanks.
Great. And Mr. Marquez, I can't remember if you were at the county when the RFP was voted upon back in 2010 or 11, but I should just encourage Supervisor Lee and myself for that matter to revisit some of the history. Supervisor Lee, we had a number of board members who had been part of that exercise who expressed concern after the fact about an interesting wrinkle that doesn't seem that central, excuse me, but apparently was part of the challenge, which is that at some point, more than a decade ago, the decision was made that board members could not communicate with the folks in the RFP process, which meant then that I think board members felt like, well, maybe some honored that, maybe some didn't. Maybe other folks in the community were able to effectively, lobby secondhand once removed. It clearly had left an unsettled feeling among the board when I arrived in 2013 based on their prior experience. And so there were a number of conversations at our board, as Ms. Lowther suggested when we were talking about the next RFP, about why don't we just say, look, this is a big deal. We're all going to have to vote on it at one point. And if proponents want to come and talk to us, they can. And let's just be open and transparent about that. And I don't have a conclusion to this story, Supervisor Lee, but and you may know this history better than I do. I don't know if it was something that you were aware of, but there was a lot of history around that process and a lot of, I'd say, unhappiness or concern about that piece of it in particular. And we just need to make sure as we go forward, Ms. Lowther and Mr. Marquez, that we have a nice, clear public conversation about that at the board, and everybody knows what the rules of the process are when the time comes.
And if I may, Supervisor, I was here, and I certainly remember that. What it was an idea that was put into the RFP itself that limited communication between any proposer and the Board of Supervisors. And I think unless there was an express waiver at the board level, something like that. And that did cause a lot of consternation, as you said. And we try to learn. And so when we did the proposal, Jackie, I don't remember if it was 2017 or 18 or 19, but whenever we did that later proposal, that provision was taken out expressly. And I would anticipate, though we have to listen to the stakeholders and go through a facilitator, that we would probably do the same thing we did back in 2017, 19.
All right.
As well.
Thank you both, Ms. Lowther and Mr. Marquez for the update. Ms. Lowther, how are we doing on our on-time arrival rates for our fire departments, San Jose in particular? Okay.
Excellent.
All right. Supervisor Lee, anything else at this point?
No, other than that, I certainly echo your comment of making sure that our process needs to be open and transparent. I think that's absolutely crucial. At the end of the day, this is a really key part of our responsibility as a county, providing the emergency services to serve everybody, rich or poor, doesn't matter. And I think it is so important to make sure that we have good services being delivered. And I certainly do believe that competition is a good thing. And when we don't have that, I certainly do think that the public option, whatever it takes to make sure that the service delivery standard is being maintained or at least being improved even would be extremely important. So I want to make sure that that all options should be on the table in the future. Thank you.
All right, thank you for that. Let me check with the clerk to see if we have any members of the public who would like to speak on this item.
We do not.
All right, then I'll ask Supervisor Lee again for a motion to receive the EMS ambulance services RFP update.
Yes, and so moved.
Motion by Lee, second by Simidian. Please call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. All right, that takes us then to item number 11, and this is our sort of wide-ranging comprehensive update. And Mr. Santiago, do we look to you to lead us through this exercise?
Yes, and good afternoon, Mr. Chair Simidian and Supervisor Lee. For the interest of time, just wanted to highlight a couple things. I don't have a written report this month, but a lot of it is verbal because of the timeliness of this. The most significant part is the Governor's May revise, which you have received a brief memo summarizing that, and particularly for our health and hospital system. We were very pleasantly encouraged that the governor has included a one-time funding for public hospital systems, recognizing their vital role in the COVID pandemic in terms of testing, vaccination, and of course, loss of revenue in order to meet surge capacity for COVID positive patients. Bert Margolin will have a little bit more details related to that because it's very much interrelated with our federal strategy of the waiver renewal as well as other reforms at the national level. The other piece that was very encouraging is that there was proposed expansion for Medi-Cal for 60 age and higher that allow for people that are, regardless of residency status, qualify for Medi-Cal. I think that was very encouraging because we know by our local experience, there's a lot of the population within that range that suffer from chronic diseases and could benefit from not just having the benefits, but also the ongoing care and prevention to make sure that it doesn't get any worse in terms of the care treatment. There was also some flexibilities in funding for telehealth, which is very important for us. It's still operating under COVID restrictions, although they are loosening up, but it's taken us a while to get back up to our pre-COVID levels in terms of utilization and access. And I think that will continue to be a very important tool for us to make sure that our patients and clients are receiving needed services. There are a couple other things that I think might be of interest to you, specifically Simidian, because you've been looking at affordability, and there's obviously continuation of the subsidies. It's a combination of both the American Rescue Plan, which lowers some of the cost for people that participate in the state exchange. In some cases, reduces the total cost to $1. Laura Rosas can give you some of the detail as part of Valley Health Plan update on that, but that's very encouraging news. That makes it far more affordable for many residents to not only continue, but also buy into the affordable coverage as offered under Cover California, as well as some of the other initiatives related to behavioral health, which both your offices have recognized as an emerging priority. Not only during COVID, but also post-COVID, that we will need to continue to address as part of the lasting impacts on underserved populations as well, people that have been disproportionately impacted by COVID. And so that gives you a little bit of the highlights. One additional thing that I wanted to also bring to your attention, concurrently with the proposed May revise specific proposal that has the creation of the Office of Affordable Care Healthcare. There's a bill, AB 1130, which we have give you a brief summary and background and prior reports, but I wanted to highlight this month for you because that pretends to have a significant impact in terms of the healthcare industry. Assemblyman Wood has been carrying this. It's gone through the various committees. It's headed for the Appropriations Committee because it has implications in terms of the state budget. But what that bill proposes to do, and the governor is including as part of his trailer bill language, is elevating OSHPOD, which is the Office of Statewide Health Planning, which we've been discussing, is the one agency that's been reviewing primarily facilities and permits and licensing. It's elevating that office to a department level and is proposing to create this Office of Healthcare Affordability to study not only the trends and cost associated with healthcare in California, but then also begin the process of gathering, collecting data, and then eventually, beginning in 23 and 24, establish targets for reduction in cost across the sector. This is something that the industry obviously has been paying specific attention to for a variety of different reasons, because affordability could mean different things to different people. We all agree with that. We don't want to discourage the appropriate use and utilization of healthcare, principally around primary care and behavioral health. But we're also, of course, all of us are looking at the rising cost of healthcare. And the big driver for the cost in healthcare is, as you know, is the providers and the salaries and the cost of living. So those are things that are actually very concerning to all of us in terms of what this might mean and how it gets applied. So this is something that will keep you posted as it moves along through the legislative process. We're anticipating that something will be passed and that will take effect. Luckily, they're considering the fact that over the last year has been very disruptive. So they're making changes to make sure that they don't benchmark it to a year that is not appropriate in terms of COVID. And then so they're moving some of these deadlines and timelines, but something that we'll bring to your attention and keep you posted very closely because it obviously will have implications for our safety net system and healthcare industry here in Silicon Valley. So with those comments, I'll end my report unless there's any questions.
Thank you very much. Supervisor Lee, questions?
No questions. Thank you.
Thank you. And Mr. Santiago, let me just ask, I actually have a couple of questions about the strangulation services expansion that we've discussed previously. To whom are those probably best addressed today?
Well, this is related to the leadership positions or the specific provision of services?
Well, this is more around the expansion of services to South County and North County for the safe sites. And I had asked some questions at prior meetings about timeline for the expansion of those services, the cost of expanding those services. And Kim Walker, I believe, is working with my office to respond. We got a little bit of a chicken and egg issue because I think she has rightly said, you know, this may all be communicated pretty clearly through the budget exercise. And what I've said in response is I don't want to show up for the budget only to discover that there's a problem at the 12th hour and have folks share information that perhaps might have allowed us to take some better action previously. So I'm happy to raise those issues with anybody on the team here today. I just wanted to ask who you thought. I see Mr. Lorenz leaning in, and if he's game, I can take the questions up with him when we get to his report very, very quickly.
Yes, related to the service status of the service expansion, that would be Paul Lorenz.
All right, then moving on to 11B, Public Health Officer. We've had the report on COVID, obviously, but let me just see if there's anything else that our public health folks would like to share with us today.
No, I think Dr. Code has left for the meeting, but if there's any questions that I need to take, we'll get back to you on those.
All right, thank you. Then, Mr. Lorenz, that means you are up, sir.
Thank you, Chair Simitian, and thank you, Renee. So you do have the written report in terms of our operations. I'm happy to answer any specific questions that you may have.
No questions on that report. I do want to follow up on the strangulation services. What's your, and again, thank you to you and your team for the work on the safe sites and the expansion and the training and the staffing that's necessary to expand those services. Where are we in your understanding on the issue of the strangulation component of those sites in terms of timing in North County and South County and funding in the budget?
The Supervisor Simitian and Supervisor Lee. So as of today, we have prepared for Dr. Smith our recommendations relative to the staffing support, which also includes the leadership structure to ensure a stable and ongoing program whereby we can continue with policy development, program planning and development and so forth, in addition to the ongoing operations. So that is something that Dr. Smith is working on with myself and the department and Kim Walker. With respect to the timing, we anticipate that we will be able to move forward with the program irrespective of staffing in terms of developing policies, the procedures, and training staff and working with our stakeholders to move forward as quickly as possible to add strangulation as part of our forensic program. So we are going to move as quickly as we can to establish that program in partnership with the DA's office and others.
And again, Mr. Lorenz, those are that expansion will be at all of our safe sites countywide?
That is correct. At all of our safe sites countywide, as well as at the Child Advocacy Center, where we are continuing to both focus on both adults and children and adolescents.
All right. Well, I think what I'd like to do on this particular matter is just ask if we get, I think at a prior meeting, I asked if we could get a report back, and I wasn't clear about whether that meant at a board meeting or just a report back off agenda. And I think doing it off agenda is probably just fine. And we'll try and coordinate with your office and Ms. Walker and Dr. Smith now that I'm aware of the fact that you've shared some recommendations with him. Sounds like the timing might end up being good to get a preview of what the budget does or doesn't hold so that we can be thinking about it before the moment when we all walk into the chambers, virtually or otherwise. Okay.
Yes, sir.
Good. Thank you. Supervisor Lee, any questions for areas that are within Mr. Lorenz's purview?
No question today. Thank you.
All right. Thank you very much. Then we will move on to the next portion here. And bear with me as I flip through my materials.
Yes, next up is the Director of Behavioral Health Services, Dr. Sherry Turan.
Hi, good afternoon, Chair Simitian, Supervisor Lee. You have our written report for behavioral health, but I could just share a couple of highlights from that report. Actually, today we held our MHSA public hearing for our fiscal year 22 annual update, and our Behavioral Health Board endorsed the plan, and so that will be coming to the full board in June. Second, we're really thrilled that we have a date next week with our with the Mental Health Services Oversight and Accountability Commission to present the plan developed by the community in Santa Clara County for our Community Mobile Response Program, which we're preparing as a Mental Health Services Act innovation project. So that will go before the MHS OAC next week on May 27th. And finally, we are preparing for our discussion with the full board next Tuesday, focused on Assembly Bill 1976, assisted outpatient treatment, and we'll be preparing a presentation for the full board next week. That concludes my updates on our monthly updates for behavioral health.
Thank you. Let me see if Supervisor Lee has questions.
Thank you. Yes. Thank you, Terry. Very Sherry, very excited the work that is being done by the Community Mobile Response Program that is being presented. So certainly looking forward for that to come through. And of course, we'll be listening to the AOT issue on the next board meeting. So looking forward to read up those good work you get putting together. Thank you.
Great. Thank you, Supervisor.
Thank you. All right, that takes us to the next item, which is 11E, Valley Health Plan.
Hi, hello, Chair Simitian and Supervisor Lee. You have our report. I'm happy to answer some questions or any questions you have. I will give you an update on our Covered California membership, which is 23,182 have signed up, 22,768 have effectuated or paid their first premium. We have been asked by Covered California to put significant resources and focus on our marketing and our outreach, which we've started doing. And we're excited to show some of that is in our report and as well as next month's report. And indeed, the American Rescue Plan has reduced the cost for most Americans for the plan, and we are open enrollment to the end of the year. So those are some updates related to Valley Health Plan, and happy to answer any questions.
Ms. Rosas, could you, it looks to me, if I'm understanding my numbers here, that you've had a pretty dramatic growth in the PCAP enrollment. Am I reading these numbers right over the last year?
I think we have had some growth in PCAP. I'm not sure how dramatic it is. I'd have to go back and look at some of the historical data, but we've probably seen some growth in that. And we've seen growth in Medi-Cal as well. So.
And any notion about what the basis for the growth in PCAP is in particular? I know working with Mr. Santiago, we've had our struggles.
Yes, and maybe I could give you a little bit more history on this one. If you remember, earlier this year, we started working on the transition to go from a program run in the health and hospital system to more towards a coverage, affordable coverage initiative under VHP. And Laura is referencing to the numbers now that obviously are in Valley Health Plan. Another significant factor here is that we stopped the discontinuation similar to Medi-Cal. If you remember, this was a program that was kind of on a rolling basis that people will be recertified every 12 months. We stopped that similar to Medi-Cal. So what we're seeing is actually people just staying longer on the program, not necessarily dropping off. And that's why you see the increase in terms of numbers. Overall, it's close to about 7,000 total aggregate number of people that are enrolled. And that's obviously an increase from what used to be a continual enrollment and disenrollment in the population.
All right. Supervisor Lee, any questions on Valley Health Plan?
Yes, so Laura, good afternoon. So with the open enrollment process, just want to make sure in terms of the language outreach, what languages do you put out regarding the new application process and all the outreach you do?
So our threshold languages are English, Spanish, and Vietnamese. We do have most of our some of our marketing is in multiple languages. Our communication as a plan has to be in a number of languages. So it depends. And I guess is my best answer to that. We are working on our website. We've just transitioned over to the new Drupal site. And so there'll be more ability to really push more material out there in multiple languages, but it's something that we're continuing to work on and develop internally as well.
Right. So I just would like to ask to see if you could outreach to some of the Asian, like Chinese media. I think it's very important for newspaper and radios of the various ethnic groups. I think that's where a lot of them do get the information. So please don't forget using those outreach process in those languages. Thank you.
Yes, sir. Thank you.
All right. Thank you. That takes us to 11F, which is EMS again. I think we probably have covered those issues, but let me just see if there's anything else under EMS.
No, we're good. Thank you.
Okay. All right. And custody health is next. Mr. Santiago, my recollection is that Dr. Day can't be with us today for reasons that are clear. Am I remembering that right?
Correct, but she did submit a written report to give you a status in terms of the testing efforts. I know that's something of interest to the committee, and she submitted a written report on that. And of course, she'll be at the second HHC meeting coming up later on, so she'll give you an update on the vaccination as well as other efforts within custodial settings.
All right, thank you for that. And then that takes us to the report relating to federal health policy and the budget landscape. And Mr. Margolin, are you there? You are.
I'm
right
here.
There. What should we know?
Well, just a few things today. I have a relatively brief report. The biggest issue in DC right now is the negotiation over the infrastructure package. The Biden administration proposal currently has no funding for hospital infrastructure. And as we previously discussed, the House Democrats put forward in their LIFT Act, that's the name of their proposal, $10 billion for hospital infrastructure. So they're pushing for the inclusion of hospital infrastructure. Last week, the America's Essential Hospital Association, the national association that represents public hospital systems, put forward the concept of a $50 billion commitment to hospital infrastructure. So it's on the table at $50 billion from our sector. House Democrats are at $10 billion, Biden at $0. Senate Republicans, the administration are going back and forth. Unclear whether we can get hospital infrastructure into this package, but there's a sustained effort underway to try to make that happen, led by the House Democrats. Next item I want to talk about briefly involves drug pricing. The most of the national focus has been on, in terms of the politics of Washington these days, has been on the 50-50 split in the Senate and the importance of Senator Manchin in that split. Well, there's a parallel dynamic in the House where the margins also razor thin. Currently, Speaker Pelosi can only absorb 3 defections on any given bill and have that bill still pass. So very tight on the House side. A development on drug pricing last week underscores that, in that Speaker Pelosi got a letter from 10 House Democrats, which includes 3 Democrats from California, basically raising concerns about the Speaker's drug pricing proposal. This is the one that passed the House in December, sitting in the Senate right now, and it's the one that essentially gives the Health and Human Services Agency department the authority to negotiate drug prices directly with the industry. It's something the industry really doesn't want at all. Pharma's adamantly opposed to, Republicans are opposed to, but it's something Democrats have pushed very hard for, this direct negotiation. This letter from the 10 House Democrats says essentially that they don't want to support any proposal that doesn't have bipartisan support and doesn't have stakeholder buy-in. And it's sort of a coded way of saying they're not for this national authority in HHS to negotiate drug prices, because that doesn't meet the test of stakeholder buy-in or bipartisanship. So Nancy Pelosi was hoping to include drug pricing in the infrastructure package, actually, as a pay for, because there are substantial savings associated with her drug pricing bill. These 10 House Democrats put that strategy at risk, and that's the latest on that front. And then the last item to briefly report on involves something Renee referenced, and that is in the May revise, the governor put forward a support for our $300 million one-time funding request to compensate public hospital systems for fee-for-service COVID-related costs. And the reason why this is important for several reasons, but it relates to our federal strategy very directly. It's important because for many years now, the state has really put a limited amount of money, of general fund money, into public hospital systems. The basic funding approach the state's taken has been to try to get counties to put up the match for federal dollars. So it's county resources matching federal dollars, and that's how our system has largely been funded. Our public hospital systems over the last year or two have raised the alarm that over time, especially with our waiver dollars shrinking, which is likely to happen in this new Medicaid waiver extension, we really need state general fund support. And this $300 million approval by the governor, at least in his May revise, we'll see if it gets into the final budget. We're optimistic it will, but still another battle yet to fight to make sure it gets in to the final budget. But the governor's support for $300 million in general fund, while it's narrowly tied one time to COVID expenses, it does suggest a state recognition that there's a need for general fund to support public hospital systems. And in that context, it's worth noting. That completes my report. Happy to respond to questions that you might have.
Thank you. Supervisor Lee, questions, if any?
Thank you, Mr. McGowan. It's always very interesting to learn what's going on in DC. This infrastructure bill with no funding for hospital is a surprise to me. So what I try to understand is that you said the House Democrats proposing 10 billion, and you say something about another $50 billion. Where is that coming from?
Well, it's from the same. It's part of the same package, but it's being proposed by our trade association. It's being put forward by the Essential Hospitals Association, which represents public hospital systems. So it's a proposal put forward by public hospitals nationally through their trade association.
I see, public hospitals.
Public hospitals. There's some non-public hospitals in the National Association, but they're basically safety net providers.
Great. Okay, thank you. Now, regarding the drug pricing bill proposed by Speaker Pelosi, what are the arguments against this proposal? What are they saying, that this is socialistic or?
No, they're not. They're not making that direct argument. They make that about the opponents of healthcare reform frequently make that argument, as you know. But in this case, the pharmaceutical industry is using the development of the vaccine to combat COVID and the other kind of pharmaceutical breakthroughs in recent years as an argument against this approach, saying that if you give the federal government the authority to drive down our prices and deprive us of billions of dollars, we'll have less money for research, we'll be less nimble, we'll be less innovative. That's basically their argument. You need to keep them adequately funded in order to make sure they can innovate. That's the argument. It's a more subtle argument than the socialism argument that's frequently raised.
Right. And alongside with that, there was some proposal about waiving the patent protection for the COVID vaccines. How did that go?
Well, that's still being discussed and debated in Washington right now. It hasn't been, I don't think it's been formally advanced, but this deals with the issue of international supply. How do you expand the supply of vaccines internationally? And to my knowledge, I don't think the Biden administration has formally advanced that. They're considering that, but that hasn't been advanced yet.
Okay, very good. Thank you very much.
You're welcome.
My question, Mr. Margolin, and it's not designed to stump you, but if you happen to have the information, I'm just curious, frankly. The 3 California Democrats who were part of the group of 10 who expressed concerns to Speaker Pelosi, if you could share those names, I'd be curious to hear it.
I know who they are. The lead Democrat, who actually was the main co-signer on the letter, is Congressman Peters from the San Diego area. And he was joined by Congressman Cardenas and Congressman Correa.
Okay. All right. Thank you for that. I had no other questions. Very helpful and thorough report as always. Supervisor Lee, one last check-in. We all good for questions and comments with Mr. Margolin's report?
Yes.
All right. Mr. Margolin, thanks so much. Let me turn to the clerk and ask if we have anyone who wanted to speak on item number 11 and all its various component parts.
We do not.
Then I'll ask Supervisor Lee if we can get a motion to receive the director's report.
Yes, receive the report, so moved.
All right, motion by Lee, second by Simidian. We'll ask clerk to call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye, and that motion carries unanimously. And that, Supervisor Lee, as you know, is the last of our agendized items that were not placed on our consent calendar. And the consent calendar items 12 through 22 were approved previously. We will therefore be adjourning now. And a reminder, of course, that we have a special meeting coming up on Wednesday, May the 26th. So thank you for that.
Apologize, Chairperson.
Yes.
On the consent calendar today, that meeting was approved as a regular meeting. It will not be
Forgive
noticed
me.
as
Then
special.
I misspoke. So I should correct that. We have a regularly scheduled meeting on May the 26th. Thank you to the clerk for making sure that it is noted properly. Without objection and hearing none, we stand adjourned. Thank you all.
The webinar will now end.
Thanks, everybody.